Hello, my testing 1, 2, 3. Hello.
So I'll start and
hand over to
the
yeah.
last.
Mm.
Ma'am, we are live now.
Yes. Is anyone
Very
to
good
talk?
evening to all of you and New Year greetings. So today is the
What
sixth
is
webinar of this deep dive into breast cancer, master course in breast cancer series, and first one of 2026. Today we'll discuss about the molecular signatures in breast cancer, and we'll start with the welcome address. For that, I will like to invite Dr. Rajiv Agarwal sir. Sir is Senior Director, Breast Cancer Services at Medanta, Gurgaon. Over to you, sir.
Good evening to all of you. Since this is our first seminar in 2026, on behalf of the organizing team, I wish you all a very, very happy, healthy, and prosperous new year. As Dr. Prekshi already told, this seminar is related to the molecular classification of the breast cancer. Over a period of last 4 decades, we have seen that breast cancer is no longer a single disease. It's a heterogeneous group of tumors with having each distinct biology, clinical behavior, and response to the treatment. So molecular classification has helped us in personalized biology driven management rather than one pill for all. And without wasting any more time, I would like to say that today's seminar, we have a very galaxy of speakers. They will be talking about various molecular aspects of the breast cancer and how they can be driven into the day-to-day management, particularly in the Indian context where low-risk patients should be avoided with toxicity and personalize the treatment. Once again, I thank you all for joining this. I thank you, my younger team, who worked day in and day out for 6 weeks to make this seminar a success. Over to Pekshi.
Hello, good evening, all. Myself, Dr. Safalta, Dr. Rajiv, I am taking over after
Oh,
this.
sorry, Safalta, please. Yeah.
So today's topic is this session of is precision in pink, decoding breast cancer's molecular identity. And in this session, we will be exploring how understanding the molecular identity of the breast cancer translate into practical clinical decisions, helping us to deliver right treatment to the right patient at the right time. To discuss this important topic, we have Dr. Sunil Pashicha, who is well-known histopathologist from at RGCI and has been one of the pioneers in molecular oncology in India. Over to you, sir.
Thank you very much, Dr. Safalta, Dr. Rajiv, and Dr. Prekshi and Dr. Vaishali ma'am for inviting me at this prestigious platform. And I wish you all a very happy new year and a prosperous new year. So can I share my slides?
Yes, sir, you have access.
Okay. My slides are visible?
Yes, they are. Slide share mode में कर दीजिए sir.
Yeah, that's what I'm doing.
Yeah.
So it's full screen?
Yes, full screen now.
Okay. So I'll be talking about the decoding the breast cancer's molecular identity. So we know that breast cancer is a heterogeneous disease and have a different histological and biological properties, and they have a varying genetic, epigenetic, transcriptomic changes, and varying clinical findings and treatment response. And this phenotypic difference influences the diagnosis, treatment, and prognosis. So currently, there are 20 major types and 18 minor subtypes of breast cancer. So here you can see that the best prognosis is determined when you actually combine not only the histological type but also with the grade and some molecular information. Like here, if you see, there are some even triple negative breast cancer like adenoid cystic carcinomas, but they are very indolent. They are not that aggressive as the conventional triple negative breast cancer that we get in our practice. Then you have a secretory carcinoma, low grade mucoepidermoid, although they are rare, but they are always triple negative. So the best prognosis can be it can be explained by combining the histological subtyping along with the grading and molecular information. And here you can see that in the this good prognosis group, you have a grade 1 invasive lobular carcinoma, but the same invasive lobular carcinoma, if it is grade 2, it has a moderate prognosis. And if you have a high grade pleomorphic lobular carcinoma, that gives a poor prognostic group, and so on and so forth. So why there is a felt need for a molecular classification? So clinical and morphological parameters currently available are insufficient to fully reflect the biological heterogeneity of breast cancer. The tumors with similar morphology and stage, they still can vary in the clinical behavior and response to therapy. The primary tumor molecular characteristics, they can be used to determine the tumor behavior and the response to a specific therapy. The molecular classifiers include genes and their products, that is RNA, and even the protein expression that we do as a very commonly in day-to-day practice, the immunohistochemistry, and that can be assessed individually, but they can also be in concert like molecular profiling. So this is a timeline of the molecular classification, the genomic landscape of the carcinoma breast. And if you see historically, the attempt started way back in 1970 when probably many of us, we were not even born at that time. And so at that time, it was done like, the tumor tissue was minced and quantitatively the ER was quantitatively determined in the liquid solution. And then we had in mid-90s, the development of the immunohistochemistry, especially the ER on the tissue section. Subsequently, from 2000 to 2010, we have described the new molecular subtypes like Claudin low, molecular apocrine, interferon-related, then gene expression-based prognostic signatures. We had like Oncotype DX, MammaPrint, PAM50. And now, in the last decade, we have seen there has been a role of a massive parallel sequencing, the integrated gene expression and DNA copy number analysis and target gene sequencing. So these are the molecular subtypes that we actually we basically classify the tumor and make the treatment decision based on these subtypes. Like we have the luminal A. So approximately 50% of the invasive breast cancer have this luminal A, and they are characteristically ER/PR positive, HER2 negative, and they are commonly associated with the low-grade tumors with the characteristic histological subtypes like tubular carcinoma, cribriform, low-grade IDC, NOS, and classical low-grade grade 1 or 2 lobular carcinoma. They show very good response to endocrine therapy. But as compared to luminal A, the luminal B, they have a comparatively higher grade, comprises of around 20% of invasive breast carcinomas. They are essentially ER positive, but sometimes they show PR down regulation, and HER2 can also be variably expressed, and they have a higher proliferation than luminal A. And the response to the endocrine therapy, although it is there, but it is not as phenomenal as you get to see in the luminal A type. So the prognosis is also not as good as compared to luminal A. Then we are familiarized with the HER2 new category. We know there is a high expression of HER2 new, and that comprises of around 15% of the invasive breast cancer. They can be dual positive, they can be ER/PR concomitant positive or negative. And then they show a response to trastuzumab. They are aggressive, they show an unfavorable prognosis. And then we have a basal-like, which shows a high expression of basal epithelial genes and basal cytokeratins like CK5-6 and the high molecular weight 34-beta-E12. And they comprises again of 15% of the invasive breast cancer, and they show diffuse TP53 mutation. They have a diffuse TP53 immunoexpression, mutation, BRCA1 dysfunction, and they are associated with a high-grade morphology. They don't show any response to endocrine therapy and trastuzumab, but however, they are sensitive to platinum group chemo and PARP inhibitor, and they have a worse prognosis. So regarding the molecular classification, we have a single gene classifier, we have a multiple gene classifier. So the single gene classifier is one of the individual molecular markers. ER and HER2 have proven of a predictive and prognostic value. They are the essential part of the diagnostic workup of all the breast cancer patients. They are determined using the standardized techniques according to well-defined published guidelines. And we are using the ESCO-CAP guidelines, the College of American Pathology. So whenever a new case is diagnosed, it is subjected to the biomarker testing, essentially undergo hormone receptor, HER2 testing, on the basis of which we formulate the molecular subtyping, and combined with the staging that leads to the formulation of the treatment decision. So these are the IACT-based molecular testing. The established one are the must-do that we should always do is the ER/PR HER2, and PD-L1 is although not a molecular target, but still we use it as a IACT-based testing. And the optional one is the Ki-67, which one should do. And one must strive to accurately measure these biomarkers because they are the integral in therapeutic decision making. Starting with the estrogen receptors, they are the more commonly used and well-established predictive marker for the consideration of hormone therapy in the management of breast cancer. They are the major classifier of the breast cancer, and ER positive and ER negative breast cancer, they have altogether different clinical, molecular, and epidemiological risk factor profiles. And IACT is the recommended assay for this. And a sample is considered negative if the immunoexpression is less than 1%. And the samples with 1 to 100% are considered positive. And for the reporting of ER, but not just PR, if 1 to 10% of the tumor nuclei, they are immunoreactive, the sample should be reported as a low ER low positive, which has been a recently recognized a diagnostic entity. So what are the issues with the low ER positive? It has the reproducibility issues with the interpretation. It has the inter-observer and intra-observer variation, the sampling issues. Significant proportion of ER low positive cases diagnosed on the core needle biopsy can convert to ER negative on the resection specimen. Therefore, as a bottom line, a repeat staining or the repeat testing of the surgical excision specimen is recommended based on the tumor characteristics and the multidisciplinary discussion. So this is the case I have captured the photograph from one of my case library. You can see a very less number of tumor cells are showing the faint nuclear immunostaining, and this black arrow is just showing you the internal control. Like these are the normal ducts and they are taking a heterogeneous staining. So the internal control tells you that the test is a validated test and you can take the results in an authentic manner. And sometimes you also have a biomarker conversion also from ER positive to ER negative, especially in a post NACT. This again, the black arrow is the internal control, the normal duct, and here you can see that the tumor is now converted to ER negative post NACT. So the biomarker conversion of ER, PR, and HER2 after NACT in a specimens without pathological complete response has been shown to have a prognostic significance with the worse overall survival for the patients that convert to triple negative status. Regarding the PR, it is regulated by ER as a ER-dependent gene product, and the presence of PR usually indicates that ER pathway is intact and functional. And this positivity is seen in 65 to 75% of the breast cancer and in approximately 80 to 90% of the ER positive cases. And the meta-analysis of the randomized clinical trials have not confirmed the predictive value of PR for the response to endocrine therapy, which is independent of ER. So there is no PR low positive category as such, and there is no evidence to suggest that PR low positive tumors can show response to endocrine therapy if ER is negative. And also there is no evidence that the predictive response of ER positive tumor is significantly different if PR is expressed at such a low level. But there are some challenges in the pathologist practice. Like you can have a ER negative, PR positive cancers, and I hope you also must have encountered this challenging situation in your practice. So whether it is a legitimate subgroup or there is an artifact resulting from the misclassification. So nowadays, only 1 to 2% of the breast cancer cases are categorized as authentic ER negative and PR positive cases. So if your institute is having a more than this percentage, so there is definitely some problem with the testing protocols. And several studies have found it difficult to reproduce the ER negative, PR positive category, and significant proportion of these tumors are reclassified as either a dual receptor positive or negative on retesting. So how to deal with this ER negative and PR positive results on core needle biopsy? One should repeat the testing on additional core needle biopsy blocks, repeat the testing on the resection specimen, and if eventually it is confirmed to be ER negative, PR positive, the patient may be offered endocrine therapies. Coming to the HER2 positive, we know that HER2 initiated signal pathways, they have a subsequent pathological consequences. And when you have a HER2 amplification or overexpression, that promotes the receptor homo and heterodimerization that causes the constitutive activation of the several downstream pathways, which leads to tumorogenesis. So HER2 testing has evolved to improve the identification of the HER2 positive breast cancer, and the ESCOCAP guidelines have actually the first, if you see, the first guidelines was released in 2007. That was based on the premise that the right patient receives the right treatment. There should be no overcall, there should be no undercall, and it focused on the standardization of the HER2 testing. Then there were some lacunae were there in this classification. So we had the revised ESCOCAP guidelines in 2013, and then we had again in revised guidelines in 2018. So we are following till date these 2018 guidelines, and then recently in 2023. There was an update, and that update was basically, there was no new change as such, but it affirms the 2018 reporting recommendations. However, the guidelines just emphasize to do a due diligence in distinguishing HER2 negative score 0 from HER2 negative score 1 plus, because earlier neither pathologists and even the medical oncologists and surgeons, they were also not bothered whether we are giving it as a score 0 or score 1, because both were considered as a clubbed entity negative. But why this was important after 2023? Because it was shown in Destiny Breast-04 trials that the trastuzumab deruxtecan was effective in the patient with the low HER2 expression, which are defined as HER2 1 plus or 2 plus with FISH negative for amplification. The same thing was reinstated subsequently by the NCCN guidelines, which commented that the distinction now from HER2 score 0 and 1 plus is very much clinically relevant, especially in the metastatic setting, since the patient with HER2 1 plus or 2 plus, which are subsequently FISH negative, they may be eligible for the treatment targeting non-amplified levels of HER2 expression. And then very recently, we have some important recommendations from the 3 international agencies few months back, from the NCCN, the College of American Pathology, and ESMO. And now what they have done is that the recent recommendation is that they have now dissected the score 0 into 2 categories. One is the score 0 absolutely devoid of any staining, that is score 0 and HER2 null. And then you have HER2 score 0 plus, which is HER2 ultra low, which is defined when there is a membranous staining that is incomplete, faint or barely perceptible within less than equal to 10% of the tumor cells. The other categories remains as it is in the previous classification. And why this has happened? Because the Destiny Breast 06 trials have shown that not only HER2 low but also HER2 ultra low metastatic breast cancer who had received 1 or more lines of the endocrine based therapy, the treatment with the TDX trastuzumab deruxtecan resulted in a longer PFS as compared to chemotherapy. And FDA has approved FAM trastuzumab deruxtecan for the HER2 low, ultra low, but on the FDA approved test. So that is very important. Like whenever there is a patient is considered for the trastuzumab, the test has to be performed on the companion diagnostic assays. These are the 4, and we are using the pathway at our institute, which is from the Roche. And the FDA also approved this pathway companion diagnostic from Roche for the HER2 low and ultra low breast cancer to receive the FAM trastuzumab deruxtecan. And also, it's very important to realize that these the low expressors of the HER2, they are frequently associated with the hormone positive cases. So you can see here, this was a large study by Schnetti et al. And you can see that in this category of the low HER2 expression, the 88% they were associated with the hormone positive as compared to the HER2 score 0, where only 70% they were associated with the hormone receptor positive, and that was statistically highly significant. Coming to the Ki-67, the ESCO and NCCN, although does not support the use of Ki-67 in the prognostic or predictive evaluation of the breast cancer, the ESMO supports the use of Ki-67 expression as a predictive of response to systemic chemotherapy, but only in the neoadjuvant setting. And AJCC does not give any specific recommendation on the use of Ki-67. However, they recommend that providers and registries should continue to collect and record the Ki-67 results. And this was the updated recommendations from the International Ki-67 in the Breast Cancer Working Group. So the general consensus was that Ki-67 has a clinical validity for determination of prognosis in the early stage breast cancer. Its utility has been demonstrated only a few small intended use to eliminate the need of the multi-gene expression assay in women with ER positive and favorable anatomic prognosis if the Ki-67s are less than 5% or if they are more than 30%. But if it is between 5 to 30%, it won't help you in making that decision whether to go for the multi-gene expression assays, Oncotype DX or not. So in the range of 5 to 30% by IACT, the multi-gene expression such as Oncotype DX is recommended by ESCO. The recent FDA approval of abemaciclib in combination with the endocrine therapy as an adjuvant treatment option for the high-risk ER positive, HER2 negative early breast cancer with Ki-67 more than 20%. And this further reinforces the urgent need of standardization of Ki-67 antibody selection and the staining interpretation. So why Ki-67 is not widely used in the clinical practice? Because the analytical validity has not been established. There is a lack of consensus on the scoring method, whether you take a hotspot or you take from the invasive front of the tumor and the cutoff values. Also the reliability of the various antibody clones and the actual clinical utility and variable immunohistochemistry protocols, because the variable platforms and various antibody clones. So recently the digital image analysis has shown a very promising to improve the standardization and to eliminate the inter-observer variation. And they have outstanding reproducibility both within and between the various platforms, including the open access platform and the higher inter-platform agreement for the digital image analysis platforms over the manual analysis supports its use in the clinical practice. Coming to the multi-gene signatures, the multi-gene signatures have been identified based on differential expression of a selected set of genes in a specific subgroup of tumors. Multi-gene signatures include prognostic gene signatures that can predict outcome. Other gene signatures have been developed based on the prediction of response to specific therapy and are used as predictive signatures. These signatures have not replaced the currently used prognostic and predictive factors in the management of breast cancer, but they provide a useful complementary information to traditional clinico-histopathological parameters in the clinically intermediate risk group of patients, particularly those with the ER positive and HER2 negative early stage breast cancer. So these are the various multi-gene assays, and we know about them that the Oncotype DX most commonly utilize FDA approved based on the RT-PCR, and they analyze the 21 genes, and they are indicated for the early breast cancer, especially for the ER positive and HER2 negative. And they basically analyze by having two groups, the premenopausal and the postmenopausal. So if there is a single node negative, but if the patient is a premenopausal, so there is no concession. The patient has to receive a chemotherapy. But for the postmenopausal, one can look for a stratification, whether it's a low risk or a high risk. And based upon that, the decision for chemotherapy can be taken. And similarly, we have some other these testing modalities like ProSigna, which is based on nanostring, analyzes 50 genes, EndoPredict, based on RT-PCR, having a 12 genes analysis, and then the MammaPrint, based on the DNA microarray, that analyzes 70 genes, and then you have a breast cancer index, which is again based on RT-PCR and analyzes 11 genes. Besides that, there are the target therapies and associated biomarker testing for the recurrent or the unresectable or stage 4 disease like the metastatic disease, and we are familiarized now with the PIK3CA activating mutations because the FDA approved agents are alpelisib plus fulvestrant, and then you have a PIK3CA or AKT activating mutations or PTEN alteration where there's a combination of capivasertib plus fulvestrant is approved for the ESR1 mutations, although the recommended method is the liquid biopsy only for this, which is recommended, and the drug approved is the Illustrant. Then you have a germline BRCA1 or a BRCA2 mutation, and the drugs approved are olaparib and the talazoparib. Then there are some very rare molecular targets like NTRK fusion. We have some tissue agnostic drugs like larotrectinib and entrectinib, repotrectinib, and then MSI height, and then tumor mutation burden. Again, if the mutations are more than the count is more than 10 mutations per megabase, we have the pembrolizumab drug, and RET fusion, you have a selpercatinib drug, which is also a tissue agnostic approval. And then there are some emerging biomarkers to identify the novel therapy for the patient with the stage 4 metastatic disease. And you have this HER2 activating mutations. There is a potential targeted therapy with a combination of niratinib and fulvestrant, and niratinib plus minus trastuzumab and fulvestrant combination. And then also the somatic BRCA1-2 mutations for olaparib and germline PALB2 for the olaparib again. So in a nutshell, these are the recommended routine use. Like if you are having a patient is having an early stage breast cancer, so definitely there is a role of the multi-gene platform. But if it's the advanced stage, there is no role of this. And similarly, based upon the early stage or advanced stage, this is in a nutshell and the routine use what we are using at our institute in this moment. And then there are some biomarkers which have a research or a limited use like TILS, HRD testing, AKT activation, NGS, and this NTRK and MSI high. So what are the limitations of the NGS testing in the breast cancer? The large number of genetic alterations identified might not be clinically actionable. Identified mutations do not guarantee therapeutic response, and targeting inhibitor that has to be proven to be clinically effective. The therapeutic effects of genomically directed therapy versus the treatment of physician choice was studied in a large study, and they found that the genomically directed therapy was not found to be superior to the treatment of the physician choice for the patient with residual TNBC after NSCT. Now there's a predictive AI system, and the next revolution is the digital pathology. The digitalization of the glass slides has led to availability of the whole slide imaging. The digital images are routinely used for primary diagnosis and the digital image analysis of the biomarkers. The use of digital images and the metadata can predict the molecular profile and prognosis. The above use is actually the path-breaking and can give additional information from the routine HE slides, which pathologists cannot analyze with the eyes, but and the AI-based software can analyze with the multi-pixel level. And there are also multimodal AI-based model from the baseline histopathology to predict the prognosis in the hormone-positive, HER2-negative early breast cancer. So to conclude, the molecular classification has provided a significant amount of additional information leading to individualized therapies for the breast cancer patient, identifies novel cancer driver genes and potentially targetable biomarkers. We need more specific predictive assays to meet the need for the personalized therapy, and the molecular classification and AI-based strategies should serve as an addition to our routine histopathological evaluation of the breast cancer, but not a replacement. Thank you very much for your attention.
Thank you, Dr. Sunil, for such a lucid talk. It is always a pleasure to learn from you. Now, our next topic is blood to bedside, the liquid biopsy for precision in breast cancer treatment. Liquid biopsies, it bridges the gap between the real-time tumor biology from blood to bedside and analysis with the help of tumor DNA, circulating tumor cells, and other blood-based markers. In this session, we will discuss how liquid biopsy is transforming breast cancer care, helping us to deliver more timely, personalized, and adaptive therapy. To discuss this topic, we have Professor Dr. Jyoti Bajpai, an internationally acclaimed faculty for her work in breast cancers and sarcomas from TMH and now at Apollo Cancer Center, Mumbai. Over to you, ma'am.
So thank you very much for this very kind introductions, and I'm, doing justice with two places. So pardon me because I'm commuting and I will be doing this presentation. So let me allow my slides to share.
Yes, ma'am, you have access to share.
Sure. Can you see my slides? Can you
Not
see
yet,
my
ma'am.
Not yet,
slides?
ma'am. Not yet.
Because I have shared it.
Ma'am, your folder screen is visible on the screen.
Oh. Let me try once more. Now?
Not yet, ma'am.
Not yet, ma'am.
I don't know where is the glitch.
Ma'am, should I share from my side?
Let me try once more. Otherwise, I think
Sure.
that would be better. Yeah.
Ma'am, if you can stop share and reshare
Yeah,
it
I
again.
think I'll just, yeah. Now? Now can you see?
Yes, ma'am, just put it on presenter mode.
Great. Sure. So thank you very much for this opportunity. And I believe that, this is truly a precision era, and liquid biopsy role, especially in breast cancer and certain segments, is increasing every day and every hour, I would say. So in next few minutes, we shall be discussing about how we are emerging in this particular space. This is my humble introduction. As was said, I was in Tata Memorial and now I'm in Apollo Groups in Mumbai. And so very brief, although I know that this will be covered by other speakers as well. So liquid biopsy can be derived from the blood and any other body fluids like saliva, ascitic fluid, urine, CSF, and pleural fluid. And essentially, it allows us to go into personalized medicine because there is an enrichment and detection from plasma or serum of circulating tumor cells, circulating tumor nucleic acids, circulating tumor microvesicles, and exosomes. So what also one small but very important point about a difference between cell-free DNA and circulating tumor DNA, because cell-free DNA essentially is a DNA segment which are associated with histones in circulation that have been released by cells, while circulating tumor DNA is derived from cancer cells and which is of importance to us. It is characterized by somatic cancer-specific alterations, cancer-specific methylation patterns, etc. And most cell-free DNA is released by normal leukocytes. We must remember this part and this differentiation. Many times, some reports, interpretation get affected by this concept as well. Higher level of ctDNA associated with certain cancer subtypes inherently, and also by high burden of disease, highly metastatic disseminated disease. We see very high level of circulating DNA, and also is one special subtype among the visceral metastasis, which is associated with more ctDNA availability. So there are pros and cons of tissue versus liquid biopsy. How liquid biopsy is important: it is rapid and minimally invasive, captures tumor heterogeneity. We know that breast cancer is no longer a single subtype. There are several subtypes. Among the subtypes also, there are several further typification. So liquid biopsy allows serial dynamic testing. For example, among the hormone receptor positive disease, also it is no longer one subtype. Even with the serial progressing metastasis, we know that there are certain early phase markers which remain stable, but there are many which keep evolving, like ESR1 mutation, what we'll see later in this presentation also. So this liquid biopsies allow us to monitor them serially and in a dynamic manner, which is very, very important. And it requires sensitive assays and high ctDNA shedding. So we have to be cognizant about this fact. It cannot completely replace histopathological assessment. It is an adjunct. And it allows targeted molecular testing, CGP, with some limitations. There are certain added advantage to tissue biopsy as such, and still it is considered as gold standard. We should remember that also, with certain caveats which are there for that methods as well. So technologies for cfDNA has to be sensitive. We know this. We'll not go into the detail. So now NGS-based ctDNA detection is kind of become almost standard. It is an optimized, NGS reduces base position error rates, and unique molecular identifiers, can be seen. It is the advantages are enables analysis of several genes, tumor mutational burden, neoepitope discovery, and DMMR status assessment. Although the high cost is still as a limiting factor, although the cost also is getting down because of definitely many players on the board, and competition is good for the patients. So which technique, PCR and DP than NGS? So the PCR detects a predefined set of specific genes alteration, mutation, deletions, fusion, CNV, and can only detect predefined mutation, hotspot mutations. Like in general, rare mutations are not investigated. So we have to be careful while we are looking what we are looking in this breast cancer, and what kind of test is really required to actually aim that. NGS allows the detection of alteration in several genes in a single test without preconceived ideas, able to detect the 4 main classes of genetic alterations also, and it can also be used to characterize new alteration. In my opinion, this is extremely important because not everything is kind of preempted. So we know that there can be many things which we discover and which can be meaningful. Mutation testing in hormone receptor positive, HER2 negative metastatic breast cancer. It is really revolutionized by liquid biopsy. The sample should be taken at disease progression for tumor genotyping. Consider tumor biopsy testing to confirm negative results. So liquid biopsy, if there is a variant detected, then consider treatment with targeted therapy. Variance not detected, we can do a reflex tumor biopsy. If still variance not detected, then consider alternative therapies. So this is kind of an algorithm, and kind of supported by the standard guidelines like ASCO. So when we should use it, this is a question which many times asked in breast cancer. So there is a change of individual mutations in the patient with breast cancer, and this cartoon is showing overall change of all mutations on the panels. So risk of false negative in ctDNA if disease is responding to therapy, that is generally if there is no shedding, because disease is really under control. So better to test for liquid biopsy when the tumor is progressing. So there is high probability of shedding, high tumor burden. So either before first line we are starting, before the start, because the tumor load is high that time, or at progression. So when we are seeing that in spite of giving therapy, there is a progression. So before starting the next line, you can test it, so that the chance of yield is highest. Do not anticipate testing when patient is stable under therapy, as a risk of false negative is very high and it will not add value. We have to be judicious, very, very cognizant, because these are having multiple implications, including a financial, because economics is also science and it is also very, very meaningful. So biomarkers for targeted therapy, what we test by liquid biopsy, frequency of level 1A biomarkers in hormone receptor positive breast cancer is PIK3CA mutation 30 to 40%, AKT1 mutation 5%, PTAN 7%, germline BRCA mutation 5%, ESR1 mutation 30 to 40%. Very, very important. These 5 are extremely important. And then important of using broad angiotype tests instead of PCR. So proportion of the 18 most frequent PIK3CA mutation, PIK3CA mutation breast cancer from a combined data set suggests that currently validated there are screen companion diagnostic PCR tests which covers 11 hotspot mutations, may not capture up to 20% of patients with PIK3CA mutation, which in my opinion is very significant number. So we have to be cognizant that why we should prefer NGS over other, and what is the added value. Longer exposure to endocrine therapy in first line increases the chance of developing ESR1 mutation during treatment. I feel this ESR1 mutation testing is one of the very, very important, added advantage of liquid biopsies in breast cancer, because this is evolving marker. This is not those early phase marker which are really stable, and we test them, we know that they are there. So with each recurrence, each progression, there are higher chances that ESR1 mutation is there. It keep acquiring. So we have to be cognizant about this, and in this context, doing a liquid biopsy is most justified. ESR1 mutation occurs almost exclusively after aromatase inhibitor in the metastatic setting, and testing for ESR1 mutation should occur at each progression on endocrine therapy if not detected. So this is the percentage this cartoon is showing. What is the percentage of ESR1 mutation? 1% during adjuvant, first line 5%, second line 33%, third line up to 40%, which is almost, just less than half. So the ESR1 testing recommendations suggest that, in breast cancer, PIK3CA mutations, ERBB2 amplification, BRCA1, 2, ESR1 mutations, MSI high, NTRK, all these things, including ESR1 mutations, are having, level 1 evidence that they should be, tested. And the different trials like PADA1 trial, there's a droplet digital PCR method was used, while in Emerald trial, the Guardian 360 was used, and with its own advantage. So the message here is tumor NGS does not replace germline testing. Also, tumor-only sequencing, there are germline variants which detected or may not detected. So there is chances of missing, a certain germline variant like PALB2 and intronic variant, especially insertions, larger rearrangements. So this false negativity, one should be aware that, testing only somatic may have chances of missing. So this should be complementary. And this slide is showing the NCCN targeted therapy recommendations. So targeted therapies and associated biomarker testing for recurrent or unresectable local or regional stage 4 or metastatic disease. So here HR positive, HER2 negative, PIK3CA activating mutations. We may do NGS-PCR. I have already told you about the advantages. And the FDA approved agents, which is very, very important, is inavolisib, palbociclib, and fulvestrant, category 1 recommendation. And so in certain circumstances, we can use as first line as well. In a similar kind of situation, alpelisib and fulvestrant can also be used, which is a preferred second or subsequent line therapy. Then in HR positive, HER2 negative cases, PIK3CA or AKT1 activating mutations or PTEN alterations can also be detected. And capivasertib and fulvestrant is having role here. All these are category 1 recommendations. This is a preferred second or subsequent line therapy in select patients. Then ESR1 mutations, NGS, PCR both, blood preferred generally, ELSA strength, as we know, category 2A recommendations, but this is an evolving marker, and if we find it, definitely we can tame it. So if liquid biopsy is negative, then we suggest to do a tumor tissue testing. So this is the ESMO targeted therapy recommendations, what we have kind of discussed. And we are seeing that there are so many players, so many kits on the block which are already there. And detecting these mutations are not only prognostic or predictive value, but there is a therapeutic relevance. So it is very, very important to detect them and appropriately target. Targeted therapy for less frequent alterations. If drugs are available, then HER2, MSI high, TMB high, NTRK fusions are also, we can see and we can appropriately target. These are the targeted therapy recommendations. Germline, BRCA, BRCA2 mutations, if present, category 1 recommendations for PARP inhibitors, NTRK fusion. We know that NTRK inhibitors, lerotractinib, entrectinib, etc. are recommended. If it is a tumor agnostic marker is like MSI high, then we know there is an indication for pembrolizumab and dostarlimab, TMB high, pembrolizumab, and RET fusion, selpercatinib. So there is plethora of data which is developing. There is so many trials. This year's ESCO and ESMO was filled with the data, which is really, really meaningful. And this year's ABSI guidelines, wherein we really formulated, and I'm very humbled that I could represent the country's voice in this advanced breast cancer guidelines meeting. And there is so much talk about these newer technologies and their meaningful, their meaningfulness in the clinics. So not only, or rather I should say, once upon a time a fancy, it's a reality today, and it's really making a difference in patients' lives. So it is extremely important to adopt these things. So to summarize towards the end, liquid biopsy has completely changed the diagnostic pathway of patients. It provides quick results, and it is useful for serial testing of alterations and the dynamic evaluation of the appearances or disappearance of some alterations. Tissue biopsy remains important. Plasma and tissue generally provide complementary information. Biomarkers with clinical utility and hormone receptor positive, HER2 negative metastatic breast cancer are somatic, like PIK3CA, AKT1, PTEN, ESR1, BRCA, germline BRCA, PALB2, etc. Multi-gene NGS testing is generally recommended by all the international guidelines like ESMO and NCCN. Tumor NGS does not replace germline testing. Timing of testing depends on the alterations. Use of plasma to detect resistance mechanisms to prior therapy should occur when the disease is progressing, like ESR1 mutation, very, very important. A negative liquid biopsy does not mean that there are no relevant alterations. One should confirm with the tissue testing. So take homes are that liquid biopsy offers a less invasive alternative to traditional tissue biopsies in patients with advanced breast cancer to examine molecular features reliably. The role of liquid biopsy should be seen as a complementary testing method to tissue-based assays, and the information derived should be reviewed in combination with tissue results. Liquid biopsy can detect mutations such as ESR1, PIK3CA that are often associated with resistance to endocrine therapy and having therapeutic targets and therapeutic relevance. Multi-gene NGS testing is recommended by the international guidelines to ensure a broad spectrum of genetic alterations can be detected. So with this, thank you very much, and sorry for a little bit technical glitches what happened. Thank you very much.
Thank you, ma'am, for such a wonderful talk as always. Ma'am, I just wanted to ask one question. Do
Yes.
you do this multi-gene assay in the first line setting in hormone positive breast cancers, the baseline?
So basically, again, it is context dependent. If patients are willing, I prefer to do that. But many times, many times not all patients are agreeing to do it first line, a broad panel. Then in that case, we can reserve it for second line also. But we have to be vigilant. But yes, my choice would be to do it a first line. Yes.
So, do you change your treatment according to the NGS report, whatever we get? Like PIK3CA mutation is there. So, do you add inavolisib in the first line setting?
So this is a bit tricky at present. So I think the practice is not entirely changed, but this is kind of a signal in our mind that we have to be much more vigilant, that this patient is having something in her genetic or somatic makeup which may leads to therapy resistance.
So, it will be more of a prognostication in the first line rather than changing of the treatment.
Prognostication, or maybe at certain situation, if you are seeing really fastly that patient is even symptomatically not getting any benefit, then we know that there is something something is there which is probably responsible. So changing therapy also would be probably faster, I would say. But these are soft things. Right now, upfront, I would not be keen to just offer that without trying on any convention.
Thank you, ma'am. Thanks a lot for joining us.
Thank you very much.
Our next topic, which is like molecular whisper, liquid biopsy in breast cancer, which is like deep diving more in the liquid biopsies and with the and to knowing about the science which is evolving in the liquid biopsy. And for this talk, we are having Dr. Aparna Dhar, who is a senior director molecular oncology at Max Healthcare. Over to you, Dr. Aparna.
All right, good evening, everybody, and thank you so much for having me here today. Just give me a sec, I'll just play my slides. Okay, so there might be a slight repetition with what the previous speakers have spoken, so I'll try and ensure that there's no repetition. Can you guys see my slides?
Yes, we do.
Okay, so I'm going to try and not bore you with repeating things, but yeah, so I've been given quite the mammoth task where I've been asked to discuss how essentially liquid biopsy and how it's actually transformed circulating tumor DNA, from what we once upon a time saw as a biological byproduct. And now I think it's a clinical oracle because it's offering real-time insights into tumor evolution, resistance, and therapeutic importance in our breast cancers. And I did see the flow of events and I did see what was being discussed. So I think we're talking more from a targeted perspective, more from treatment, clinical, Monday morning practice. What can we incorporate? So I've tried to stick more to advanced and metastatic, but there's so many facets to liquid biopsy. I'm always happy fielding questions regarding those facets post this talk. So when we think about liquid biopsies, when we think about, NGS and, CGP, as Dr. Sifalta just asked Dr. Jyoti earlier, that do we do it upfront? So in lung cancer, it's a no-brainer. We do think about doing liquid biopsy or tissue biopsy or some form of NGS, but we do it, right? So before we jump into seeing how much of liquid biopsy do we use in our clinical practice, let's go and see, is there really any role of basic profiling in breast cancers? So can someone just confirm if my slides have moved?
They're moving. They're moving.
Yeah. Okay, fine. Cool. Thank you. So this is a very, very basic view we see of our patients with breast cancers. They get classified, based on the ERPR HER2 status. ERPR positive, the hormone positives are more commonly seen. In our neck of the woods, triple negative is slightly higher versus what we see in the Western population. And then you have your HER2 positives. But when we actually look at breast cancers today, and I obviously see from a very different lens, what we've seen is that we've moved beyond those intrinsic subtypes, where you're looking at luminal, basal, HER2 positive subtypes, and you're now looking at the genomic drivers. So you're looking at alterations in the PI3K pathway, you're looking at the DNA damage repair pathway, you're looking for resistance mechanisms. In fact, you're preempting resistance mechanisms by maybe sometimes profiling earlier, doing liquid biopsies earlier to kind of pick up, is there a lurking ESR1 mutation? Is there an RB1, which is usually acquired? And we'll discuss that in a bit. But we are doing this proactively. And the whole purpose, another great line is FGFR. So what we are trying to do is we're trying to see how can we target in a more precise fashion. So this was, I think, one of those initial studies that came out that I think very beautifully illustrated the molecular landscape, and it showed that breast cancers are actually very heterogeneous. And what you can see over here is that if you look at the subtype of the HR positive or even the triple negative, there's a plethora of somatic aberrations that can occur. But what we also saw was that if you compared the difference between the primary and the metastatic site, there are at least 9 driver mutations. You had your TP53, your ESR1s, your AKTs that were more frequently mutated in your hormone positives, especially so it was metastatic breast cancer versus early breast cancer. And what we saw with our metastatic triple negatives was there was an increase in the frequency of biallelic losses of function in genes that were related to your homologous recombination repair. And what we also saw with metastatic breast cancers is there was an increase in the mutation burden and there was clonal diversity compared to early breast cancers. And this is where our interest started that, all right, there is some info over here. Maybe next generation sequencing profiling could be of some help. So looking at this, we thought, and this is just me trying to put all the info together, let's build an algorithm. Now, the poster child for this is always lung cancer, but let's try it with breast. Now, what this does over here, this is a very simplistic view, right? So what I'm doing, I'm saying here that this is breast cancer. And what this is essentially alluding to the fact that you only have 3 biomarkers, ER, PR, HER2/neu. You are saying that the biomarkers are static, and we know in about 30% of our patients on progression, there can be a loss or gain of function. And it also assumes that there's only one activated pathway, and which is dominant. So again, what we're going to see is that there's so much crosstalk between different pathways. So this is something very simple, but we're now going to go and deep dive a little bit. Let's start with triple negative breast cancers. So if I look at the biology of triple negative breast cancers, we know that they're typically associated with the worst prognostic outcome. And if you can see from this heat map over here, patients with triple negative breast cancer, it's not as straightforward as we think it is. Even amongst these group of patients, there are subtypes like luminal, AR, mesenchymal, basal immune suppressed, basal immune activated. And again, amongst these, there are therapies there are different therapies that are involved. I know Dr. Rajat is speaking more on these subtypes, so I'm not going to go much into it. But if you can see over here that what seems very simplistic, it is actually a little bit more complicated than just being triple negative. And when we think about doing comprehensive genomic profiling, I think something that we frequently see with our triple negative breast cancers is your TP53, we do tend to see your TP53s, but in addition to that, what you're also starting to see is that you have defects that we see in the DNA damage repair pathway, where you know that you've got PARP and platinum therapy that have clear roles. You could have targeted therapies you could target the inflamed phenotype, which is essentially your immune system, where immune checkpoint inhibitors have a very, very clear role. A very simple IACT marker, AR. If it's positive, we have drugs for that. And again, over here, the PI3K pathway, if positive, we have mTOR inhibitors. We even have AKT, where there's some data of the role of capivasertib in triple negative. Obviously not the strongest as it is in hormone positive, but there is some information that is coming about here. In addition to that, you also have your agnostic markers. Don't forget your NTRK fusions, your BRAF V600E, your RET fusions. Go back and double check and see the status of your HER2, because we know with all these various trials, if it's HER2 2+ or even 1+, in some cases, we can give trastuzumab deruxtecan. So it is pretty, it is quite diverse. And this was a very nice paper where they did CGP for triple negative breast cancers. And what they also saw over here, it just went back and reiterated what I was showing you earlier, that all these various pathways, TP53 is the most common that we tend to see. But in addition to that, you have your BRCAs, you have your PIK3CAs, you have your PIK3CAs, you have your RB1s, you have your RAS mutations, your cell cycle pathway. So there are a plethora of biomarkers that are available, maybe not all actionable, but they do tell you about the biology of the tumor. Another very interesting factor that came out from that subset was in triple negative breast cancers was having BRAF mutations. Now, on BRAF alterations, we do tend to see point mutations, we do tend to see fusions. And a very interesting thing was that in all of this, I have seen in a couple of cases, and some great case reports that say in the presence of a BRAF mutation, especially those class 2 mutations, or even some class 1 mutations, while yes, class 1, your BRAF V600E, you give DEBRA plus trametinib, but what it also does is it makes your immune environment hot, so which means that you can give immunotherapy as an option. And there's some great case studies where there's no major clinical trial, but there are very good case studies where we have seen that these do result in a higher TMB, which in turn means it favors immunotherapy, especially in the presence of these BRAF genomic alterations. Now, let's move on to our hormone positives. I think hormone positives is one of those areas where understanding the biology has become extremely important and should actually be our standard of care. So ER/PR are your drivers. You have your ESR1 mutations. We know that if you acquire these ESR1 mutations, aromatase inhibitors don't work. You think of something like fulvestrant. We now even have ESR1 targets, elacestrant, which is available. Then in addition to that, you will see defects in the PI3K pathway. You will see defects, you will see defects in the DNA damage repair pathway. So if you have a germline BRCA1, BRCA2, even somatic BRCA1, BRCA2, and germline PALB2, these are areas where maybe, a PARP inhibitor will have a role. We also know that in the presence of BRCA mutations, especially a BRCA2 mutation, CDK4/6 inhibitors, for some reason, do not work very well. There is a crosstalk because of which there is resistance and they don't have the best outcomes. They don't have the best responses on a CDK4/6 in the presence of a germline BRCA, and BRCA2 is more prevalent than BRCA1 here. In addition, you again have your agnostic markers. But for me, I think this is a more practical approach of what happens in our clinic, our day-to-day clinical practice. This is what we do tend to see with our hormone positive patients. But I want to draw your attention here. So all this time I've been, talking about how in our HR positive cohort, I think understanding the biology definitely is important. And the reason is that, these targets are not static. So what happens is they're just not kind of on their own. They're somewhere interconnected in this tight mesh of signaling that you can see here. And I'm going to just simplify it into 3 very, very simple points. So I always use this triangle to emphasize the 3 most important angles, the 3 most important nodes, which are there in the signaling network. On one hand, you have your estrogen, you have your sorry, I don't have my glasses, I can't see clearly. You have your estrogen receptors over here, and then up there you have your PI3K, you have your CDK4/6. Now, what we've seen is that whatever you do in an ER positive breast cancer with one of the angles is that when you go and block one angle, the other 2 get activated. So somewhere over here, it is an adaptive increase that if you go and block, let's say just the PI3K, the ER and the CDK4/6 get activated, they get activated. So that's one of the key reasons if you saw the clinical trials were more with doublet therapy, and we don't really treat independently, especially when we know there's a PI3K mutation, you are kind of controlling all the various angles. So this is how we're moving towards maybe triplet therapy, where we're going to try and prevent this adaptive response and shut down all the signaling. We do know that there are some great trials. That is there, the INNOVA trial, INNOVA 120 trial anyway had that data of looking at this from a triplet perspective. So that's why the biology in hormone positive becomes extremely important. What I thought was very fascinating with breast cancers when I was actually doing some of my, kind of putting info for this talk was that when they actually analyze, and look at this is a huge data set of over 58,000 patients where they did plasma testing, ctDNA testing in metastatic breast cancers. there are quite a few fusions that are available. And in fact, there is one case that was presented at ESMO last year from the FMRI team, Dr. Nitesh Rotagi's team, of this particular patient who was a known triple negative, metastatic triple negative breast cancer, was started on standard of care treatment. Then they did a liquid biopsy because she very rapidly progressed. Something did not seem right. They picked up an ALK fusion. She was starting on alectinib back in November 2022. And till August 2024, she continues being disease-free and continues being on alectinib. From what I remember, when he last presented this case, the patient still continued being disease-free. So liquid biopsies, ctDNA testing, or rather NGS, does have a role, especially in these patients. What was again another very interesting thing was the role of MSI high in our breast cancers. Now, breast cancers, MSI is not really synonymous, but what I found interesting here, yes, it's a very small percent of just 0.63% that actually ended up being MSI high. But when you look at that huge cohort of patients, I know it's minuscule, but we do tend to see MSI high even. And when they are MSI high, they have had a good response. And I think that's the key takeaway from this particular study. Now, ESMO has come out, and Dr. Jyoti has already discussed this, has come out with a scale for clinical actionability with molecular targets. So what we see here are level 1, level 2, and these are our usual suspects, our usual players. But I am more excited about this page, which is where there are a lot of clinical trials. There's not the greatest evidence yet, but it is, a lot of clinical trials. And this is what we're learning from CGP, that the more we start doing testing, the more we start understanding the biology of the cancer, what you do start seeing is, apart from those level 1 evidence, level 2 evidence, those classic suspects, you are starting to see that there is a crosstalk with a lot of other oncogenic drivers, a lot of other tumor suppressor genes. And honestly, next generation sequencing, the results that you get from there is the way that the tumor is communicating to you. We just need to learn how to translate it. And I think all of us in a collaborative way do try and understand how to translate this. But all this information does help us with how we should be treating our patients going forward. Now, some of the most common resistance mutations we have heard of, ESR1s, this usually emerges under selective pressure from endocrine therapy. And this leads to a ligand-independent estrogen receptor activation. One of the best ways to actually pick this up is on liquid biopsy. And I'm going to show you a study. I'm going to show you a case example just in a little bit. So I think ESR1, brilliant platform to do it is ctDNA. Another very important one to look at is RB1. Now, this is acquired. So when you start a CDK4/6 inhibitor, you're not going to find RB1. This is something that is acquired because the RB1 loss actually disrupts your cell cycle control. And what that does, that mediates resistance to CDK4/6 inhibitors. So if your patient does progress quite rapidly on a CDK4/6, RB1 should be one of your first suspects. Now, apart from that, like I said, that when we're doing comprehensive genomic profiling, what we are starting to see over here is that there are a lot of alterations in various pathways. And this was, again, around a sample size of over 8,500 breast cancer patients, mostly defined, you've got your hormone receptor positives, you've got your hormone negatives, you've got your triple negatives, you've got your HER2 positives. And I thought it was brilliant when we look at the kind of molecular profilings that we were getting and where we had some element of targeted therapy. Yes, not level 1, I understand, not level 2. But when you're kind of starting to, patient starts to progress on first, second line, you are kind of forced to become a little bit innovative and creative. And we do have this sort of information. So it goes back to my question, is it really worth doing molecular profiling in breast cancers? Absolutely, yes. I've just kind of taken everything together and just put it into this flowchart, just a little flowchart to understand various treatment options, what are available over here. So is liquid biopsy the molecular whisperer? Absolutely. I think liquid biopsies is a fabulous platform in actually picking up those mutations. It's the way the tumor is whispering and talking to you and kind of telling you that, hey, a resistance mechanism is around the corner, or some, changes are around the corner. And if you have a good ctDNA platform with a good depth of coverage, a good assay, it can actually pick up these resistance mechanisms, which can allow you to change treatment at the right time. Now, one of the key areas where we have seen liquid biopsy to be phenomenal, we know, as I showed you earlier, breast cancers are very heterogeneous diseases. You do have intra and inter heterogeneity. Obviously, there is a difference, but we are seeing even, I don't want to use the word discordance, but you can see that there is a difference in the molecular profiling or the genomic profiling of the primary side and the metastatic side. And I think liquid biopsy is a fabulous tool to use. It has so many functions today in breast cancer. We can use it in early screening where we can, kind of identify individuals. Again, I'm going to take this with a pinch of salt. The data is not strong. It is still work in progress, but they are using ctDNA to actually pick up cancers even before they present. So they use methylation signatures. Two, we use it in minimal residual disease. So now it's very strong evidence is there with respect to gastrointestinal cancers, in particular your colorectals. But in breast cancers also, there are recent studies that we saw at FSIBC, ASCO, ESMO, where they are showing that MRD slow and steady will have a role in our early breast cancers and our locally advanced breast cancers. And then obviously we are using it from, monitoring treatment responses for identifying actionable mutations. So that practice is definitely there. I think what the MIRROR study very beautifully did, it showed that there was definitely concordance between tissue and liquid. It showed us that liquid was not inferior, but it also helped address the issue that when you have progression, do I need to do a rebiopsy? Is it really worth doing a rebiopsy? Is there a difference in the molecular profile of the metastatic site and the primary site? And I think this very beautifully illustrated liquid was not inferior. And two, when there is disease progression, the metastatic site can have a different genomic profile or can acquire resistance mechanisms that will be missed out on your primary site. And liquid had a far more better pickup rate than tissue. This was another real-world evidence where they looked at patients, around 4,400 odd patients. This was a liquid biopsy, where again, what we saw was that breast cancer patients are very heterogeneous. And you can see there are so many mutations, TP53, PIK3CA, ESR1, EGFRs, that's another area. We do tend to see a lot of EGFR, especially T790M in our triple-negative breast cancers. Interestingly enough, if the VAF is high, do check for germline because germline, EGFR, T790M are seen with triple-negative breast cancer, so they increase your risk of triple-negative breast cancers and lung cancer. So again, what you see are a plethora of mutations that are there, which are potentially actionable. Another study that shows comprehensive profiling is important. The groundbreaking work came about with the plasma mat study, which was one of the largest studies that were done with ctDNA testing to show the utility in of matching, molecularly matching your patient with targeted therapy based on their molecular profile. And what they did over here in particular, I'm not going to go in the study, but what I did enjoy in the study was they showed that they compared two liquid biopsy platforms, NGS versus ddPCR. So what they saw is that next generation sequencing, Dr. Jyoti already spoke about the difference between hotspot and full gene coverage, that actually with NGS, you had full gene coverage, so you picked up novel mutations, which means more patients were molecularly matched. The sensitivity was better. And those patients that molecularly matched definitely did better. We've heard this time and again. And they've done this across the board with all various permutations, combinations based on the ER/PR HER2 status. Another great study was to do a head-on-head comparison with tissue and liquid. Again, what they saw over here, that liquid was definitely not inferior to tissue. So when you have a metastatic disease, you have advanced breast cancers, liquid biopsy is a good platform. And this is what I was discussing earlier about ESR1 mutations. So this was actually presented back in 2018 by Dr. Chandrila Bhatti from the MSKCC group. And what I thought was fabulous is if you see over here that when they tested on the tumor in 2050, in Feb, no ESR1, right? And we do know sometimes ESR1s can be there from the beginning. Some small subclonal activity could be present. The tumor picked it up in, obviously later when I'm guessing there was a progression. But if you see when they did ctDNA around the same time at diagnosis, there was an ESR1 sitting at 0.04%. So ctDNA is good at picking it up. Here again, they did ctDNA plus tissue testing. I'm not saying tissue is inferior, but liquid biopsy is a good platform in actually picking it up. And I think these studies speak for themselves. The negative is that if you don't have a good assay, and if the right assay is not as per the not as per the AMCAP guidelines, then yes, your liquid will be an inferior platform. For it to not be inferior, certain guidelines in the assay have to be maintained. Now, another excellent area of liquid biopsy is a role of BRCA reversions. BRCA reversion is a phenomena whereby in a known germline BRCA mutation, what happens is that post multiple lines of treatment, somewhere based with treatment pressure, the patients, the tumor is able to kind of partially repair itself. So maybe not get a full repair, but partially go from mutant to wild type, which is where we tend to see resistance mechanisms come in. So liquid biopsy is a great feature. Another brilliant area that is coming along is the epigenomics part. This is the methylation signatures. Methylations are essentially unique signatures, DNA fingerprints for every tumor. And we are using this BRCA1 methylation. We do tend to see in 25% of our triple negative breast cancer. So sometimes germline is negative, somatic is negative, everything's negative, but the patient is showing an element of BRCA-ness. It could be because there's a methylation signature. So in our clinic, what do we do with our medoncs? Very quickly, upfront, if it's metastatic breast cancer, if cost is not an issue, we do like doing liquid biopsy. We do like doing NGS of some form, but honestly, not everybody's up for it because your standard of care doesn't change. So first line usually continues as per the standard of care. If there's progression, if there's any oddity in the responses of the patient, that's when we go ahead and we start doing CGP. If cost is not an issue, tissue plus liquid. If cost is an issue, if I have a new primary site, we will do tissue. If tissue does not give me great information, maybe we'll switch to liquid. But I think at that point, we debate and see as to what would be the best option present. I know I've overshot my time, so I'm going to very quickly skip through these cases, but I'd be very happy to field any questions, at the end of this. So yeah, thank you so much for your patient listening. Thank you.
Thank you, Dr. Aparna. It was so beautiful talk, and it was like we were sailing through the liquid biopsies, and thanks for all the replies. Now coming to the next topic, which is beyond TNBC, and we know that TNBC from previous talks that it's a heterogeneous disease, and the issue is it's not just chemotherapy. TNBC already, like Dr. Aparna has already elucidated what there are many mutations over there. In this session, we will explore why this subtyping matters and how is reshaping clinical decision making, and how a deeper biological understanding of TNBC can help us to move from empiric therapy to more precise and personalized care. To discuss this topic, we have Dr. Rajas Saha, Senior Consultant, who is Unit Head, Medical Oncology, RGCI, and who is known for his calm, poised nature as a person and patient-centric approach. Over to you, Dr. Saha.
Thank you very much, Dr. Safalta, and I would like to congratulate Dr. Aparna for an excellent and very exhaustive talk. I feel like I should give a summary of whatever she has presented, because she has covered a lot of the points, and probably better than me in explaining the entire thing. So I would like to just project my slides.
So your slides are visible. Just put it on presenter mode, sir.
Yeah. Just tell me whether it is moving or not, because sometimes it gives a problem.
Sure, sir.
So the topic which has been given to me is beyond TNBC, why subtyping matters. So yes, just to see what is TNBC. The TNBC is very easily a lack of ER/PR HER2 expression. So that is I would say it is nowadays a primitive definition of TNBC. Statistics wise, it is comprising about 15 to 20% of all breast cancers. Clinical profile, it is definitely a higher grade, more aggressive, higher prevalence in younger patients, more prevalent in certain ethnic populations, higher likelihood of BRCA mutations are there. So definitely the clinical problem which we face in our clinics is historically it has been treated as a single entity. When we are taught that it is a single entity and we have to treat it with chemotherapy. Not much of targeted agents are available. But what we see is that clinical responses vary widely. So Dr. Aparna was rushing through could not complete the case scenario. So there are certain cases, these are few of my real life case scenarios. A 55-year-old lady, TNBC, post NSCT, post surgery, had a PCR but relapsed after 8 months. So what did we do wrong? I don't know what did we do wrong. We have another case, a 38-year-old lady. We know her younger the patient, more aggressive the tumor. It was also TNBC. We did NSCT, we did surgery. Patient had residual disease, generally not so considered to be a good patient. If patient is not having a PCR, patient was given capecitabine. Patient is continuing to be disease-free at 2 years plus. So these are just one or two things just to set our minds racing ki TNBC per se is not a homogeneous disease, it is a heterogeneous disease. So investigators have tried doing subtyping of TNBCs. So it all started in a systematic fashion by Lehman et al. In 2011. He first identified 6 distinct subtypes. Then he refined the 6 different subtypes to 4 different subtypes. Parallel models were made by other investigators also in the lab. Bernstein, he defined 4 subtypes, and the Chinese group from Shanghai, the Fudan University group, also devised a 4 subtype model. So the goal of subtyping, why? Because we want to kind of answer why one patient is responding differently from the other patients, and hence leading to the goal of subtyping. And what we need to do is we need to transition from standard cytotoxic chemotherapy to precision medicine. So this is just a pictorial diagram of the evolution of the various TNBC subtypes over the years. So just means this is the first paper by Lehman et al. In the Journal of Clinical Investigation, 2011. So they analyzed about 587 triple negative breast cancer patients, and this is the heat map signatures. And they identified 6 different subtypes, and they kind of did a grouping of all the mutations, and they identified 6 different subtypes: the basal-like 1, BL1, basal-like 2, immunomodulatory, mesenchymal type, mesenchymal stem cell type, and luminal AR type. So this was their subsets, and each of them had certain characteristics. The basal-like one had a cell cycle and DNA damage pathway predominantly affected. The basal-like 2 had growth factor signaling overexpression and metabolic pathway involvement. The LAR, or the luminal androgen receptor type, had hormone regulation and metabolism pathways which were affected. The mesenchymal type had increased cell motility and activation of the epithelial mesenchymal transition. Mesenchymal stem cell type was similar to M type but with a low claudine expression, and the immunomodulatory IM type had a higher tumor mutational burden, higher immune profile, higher tumor infiltrating lymphocytes. So these were the 6 Lehman subtypes of triple negative breast cancers, and what they did a clinical correlation was that the percentage of PCR, the PCR is always considered to be the holy grail of neoadjuvant chemotherapy in breast cancer. A person who achieves a PCR definitely performs better in the overall survival. So the probability of PCR increase differs from the different subset. The BL1, if we can see, the BL1 subtype had about 50% PCR rates. The immunomodulatory and the mesenchymal types jointly had about 25 to 30% of PCR rates. The mesenchymal stem cell-like had only 20% PCR rates. The luminal androgen receptor type had only 10% PCR rates, almost similar to the ER-positive patients also. And the BL2 type had no PCR rates recorded in this subset of, in this cohort of the patients. So that's a huge variation of responses seen with our standard chemotherapy. So this is where we can pick up certain promising therapies also. So subsequently, Lehman in 2016 further refined it to 4 subtypes, and these were the 4 subtypes: the luminal androgen receptor type, the BL1 type, the BL2 type, and the mesenchymal type. And obviously, the overall survival they demonstrated, and the overall survival also, the BL1 subtype fared best, and the mesenchymal type and the luminal androgen receptor type did not fare so well. So these were the 4 subtypes. So this is considered to be the gold standard for a long time: basal-like 1, basal-like 2, mesenchymal, and luminal androgen receptor type. Then Bernstein et al. Also did their study, and a comprehensive 198 patients samples were analyzed, and comprehensive genomic analysis was done on these cohort of patients. And they found out that there were 4 clusters of patients. One was AR positive, almost akin to the LAR type. Second cluster was the mesenchymal type. Third cluster was the basal-like immune suppressed type. Fourth cluster was the basal-like immune active type. So again, there were various other targets based on that. So this is just a slight description of what is basal-like. Basal-like is basically characterized by MYC amplification, higher TP53 mutations. It is most sensitive to standard chemotherapy, and potential targets are platinum agents. And if these are the patients who are highly likely to have BRCA mutations also, and if found, then we also have in the metastatic or in the adjuvant setting olaparib to give to these patients. So this can further be divided into BLIA type, which is the immune activated type, which is a higher expression of CTLA4, PD1, and PDL1. Prognosis wise, it is the best overall survival. And these patients on histopathological examination will have a higher tumor infiltrating lymphocytes in their specimen. The therapy, these are prime candidates for the addition of immune checkpoint inhibitors. So immune checkpoint inhibitors, as per the trials, we generally give to all patients of triple negative breast cancer. But if we are now doing the subtyping, we realize that it is beneficial in only the BLIA subtype of breast cancers. The BLIS subtype is the basal-like immune suppressed type. So here there is a down regulation of antigen presentation. So that means the tumor mutational burden, the immune mutation profile is not very high. Prognosis wise, it is the worst overall survival and requires a combination therapy to prime the immune system. Generally, the immunotherapy generally will not probably work in this kind of a woe. And PDL1, which is generally taken as the de facto marker of immune therapy, generally is not a correct way to kind of predict the BLIS subtype. So hence the importance of doing a NGS to kind of tease out these subsets. This is the mesenchymal stem cell type group is there. It contains mutation in the cell migration genes. It promotes epithelial mesenchymal transition, has a higher propensity for visceral mets, especially lung mets. Generally immunosuppressive environment, so hence the tumor mutational load is very less, and hence probably not so very responsive to immunotherapy also. So this cohort of patients, this proportion of patients is also not very doesn't have a good overall survival and kind of a poor prognosis patient. Next is the luminal androgen receptor subtype. These are generally predominant in the slightly elder population. They have a AR receptor expression. They also contain higher proportion of HER2/neu mutations, even though TNBC by definition HER2/neu should be negative, but they contain HER2/neu mutations. So nowadays they can fall in the realm of the HER2/neu low or ultra low, and they contain higher proportion of PIK3CA alterations, higher prediction of bone mets as compared to visceral mets or lung mets. Again, I would say that these patients are also not very responsive to the standard chemotherapy, and overall the prognosis is not so good. Earlier it was considered to be a good subtype, but nowadays I will show you in one study it is not so good. And so this was what is the Bernstein model. So we have seen the Lehman model, we have seen the Bernstein model of 4. Next, another group, the Jezekel, Pascal Jezekel et al. Group identified 3 subtypes. So C1, C2, and C3. And this is just a representative kind of a bar diagram of the representation of the C1, C2, C3 model with the Lehman 6 subtype model. So kind of overlapping is there. So here we can see that the C1 is a molecular apocrine phenotype with better prognosis, which is akin to the luminal androgen receptor. And the C2 is basically containing more of the basal-like features and the overexpression of the cell cycle receptor pathways. And the C3 is basically the immunomodulatory type, which is the IM. It corresponds to the IM type of the Lehman pathway. So overall, yes. So a lot of investigators in different countries are doing this subtyping, and all of them are trying to kind of answer one basic question: are we able to kind of tease out which patient will respond to which drug? So this is another group from the Shanghai, the Fudan University from Shanghai. So they also analyzed their group of TNBC patients, and here they included a lot of things. They did multi-omics profiling. So they did the mRNA profiling. They also did the long non-coding regions of mRNA to accurately characterize the triple negative into their four subtypes. So they are also having these four subtypes: the LAR subtype, the mesenchymal subtypes, the basal-like immunosuppressive subtypes, and the immunomodulatory subtype. So this was their findings. So in this, this is called the Fudan classification. The four subtypes of Fudan classification. The BLIS is the basal-like immunosuppressive, very poor prognosis. So TP53 highly mutated, high copy number alterations, and treatment. It has got a low HRD score and overall a very poor prognosis. The immunomodulatory type, good prognosis, high chromosomal instability, and they respond well to the immune checkpoint inhibitors. The luminal androgen receptor subtype have a higher prevalence in Asian patients as per their cohort of patients, and they are more elderly related to the apocrine differentiation. The PIK3CA alteration is highly expressed, and there are 9% of patients who have got the ERBB2 mutation. Low chromosomal instability, and they respond somewhere to endocrine therapy and or CDK4/6 inhibitors. The MES subtype, the mesenchymal subtype, poor prognosis, and mutational profile is somewhere between the luminal androgen receptor and the other basal-like groups. And here we are definitely at a shortfall that we don't have much of targeted agents. We have got JAK-STAT pathway inhibitors, which are still in clinical research. So this Fudan classification came in year 2019. The further classifications people are doing now, we are definitely moving from a simple gene expression profiling to mRNA. mRNA we are already doing now. As Dr. Aparna also mentioned, that DNA methylation patterns are being studied a lot to see for any epigenetic changes and also take a pattern out of them. Metabolomics is there. So the specific metabolic pathways of the breast cancer are being studied. The metabolomics is there. Tumor proteome analysis is there. Tumor microenvironment analysis is there. So all these different analysis are being done to create a comprehensive subtype of triple negative breast cancer. So there is tremendous advancements, and especially upon using AI and ML, but obviously till date there is no utopian classification of TNBC till now. So technically in our clinics, what we are doing right now, I think so based on the previous few slides, we are still very primitive. We are screening our patients of metastatic triple negative to PDL1. If PDL1 is higher than 5% or 10%, we are treating with pembrolizumab and chemotherapy, or atezolizumab plus chemotherapy. If patient is having a germline mutation, we are treating with PARP inhibitors. And we know that they are probably going to get a better outcome with platinum agents. If PDL1 negative and germline BRCA negative, we are generally going ahead with a ACT kind of a regimen. And if anything is unknown, we are still searching for new biomarkers. So this is a very simplistic thing which we are actually doing in our clinics today. So what we should do is guided by this trial, which is the future trial. Now, this future trial was done by the same Fudan group from Shanghai. So now they kind of stratified their patients, refractory metastatic TNBP patients, into various subtypes. So LAR subtype, they further classified on the basis of the HER2 mutation, yes or no. Immunomodulatory subtype was generally treated with the anti-PDL1 antibody. The BLIS subtype, the immune suppressive subtypes, were again differentiated between BRCA1 mutated or non-mutated, and the mesenchymal subtype was again stratified according to the PIK3CA mutation. So I have just picked up one overall response rate slide and the forest plot from the entire future trial. And here we can see this is a very surprising finding, even though the numbers are low in the androgen receptor expressing patients. And if the patients are given an androgen receptor blocker, but still they are not responding so well. The overall these are the 20 patients. These are the 20 patients of the LAR subtype who are treated with an androgen receptor blocker like enzalutamide, but they're not showing much of a response. So food for thought, the androgen receptor may be a biological marker, but it is not a targetable or a driver marker probably in such patients. And in my personal experience also, if we have treated with, we always are very excited if a AR receptor comes up, but somehow it generally does not give that much results as a ER receptor positive case does. So that is something to be thought of. In the immunomodulatory type, definitely it shows the best response with anti-PD-L1 things. In the mesenchymal type, as also in this subtype, which is the basal-like immunosuppressed subtype, we can see that they are responding somewhere to the VEGF kind of treatment. So VEGF are blockers or VEGF inhibitors. So this is a food for thought for us, that we can definitely add on either bevacizumab or some other small molecule VEGF inhibitors and get some response in these patients. So the learnings from futures trial, LAR subtypes may not be the AR receptor may not be a driver marker. Immunomodulatory subtype has 43% overall response rates in the refractory setting. So definitely the way to go. Basal-like immunosuppressed shows impressive 28% overall response rates with the addition of anti-VEGF to the chemotherapy. So yes, we should probably take hint from this trial and probably start doing it. Mesenchymal type has a poor outcome and definitely needs a breakthrough treatment. They have again the same group, the Fudan from Shanghai, Fudan University Shanghai group, have now designed a future super trial, which is based on the patients of the first line metastatic. The future trial was refractory metastatic patients, and this is the first line metastatic patients. And here they have taken this cohort of IM type, the immunomodulatory type, whereby they have shown that if we are doing a subtyping based treatment guidelines, then the patient is having a 15.1 months progression-free survival vis-a-vis 6.5 months with the standard of care. If we are taking the BLIS, the basal-like immune suppressed type, here also we can see that the subtyping based stratification and guidance based on the subtype and the treatment based on the subtyping, definitely there is an improvement in the PFS. And also in the luminal androgen receptor subtype also we are getting a improvement if we are doing our treatment based on the subtyping. So the preliminary results of the future super trial was that the median PFS was significantly longer in the subtyping based group. That means that means these patients are given treatment guided by the subtyping, and it's 11.3 months versus in the control group, which is 5.8 months. Hence, prompting them that group is definitely doing that subtyping based treatment, and probably we should also in the future probably get something in our guidelines that this patient should receive immunotherapy, this patient should receive an mTOR inhibitor, etc. Hence the need to do NGS upfront in our TNBC patients. Just to summarize, a look into the future, what the investigators are doing. The advance in the AI subfields of machine learning and deep learning has produced powerful tools that can be leveraged to construct models. Now, the deep learning methods are extracting information from non-molecular data types. So we are doing NGS. That is what I discussed in the previous slides. They are now combining it with the clinical findings. They are now combining it with the imaging findings. They are now combining it with the whole slide imaging, so histopathology, and they are integrating everything, and they are significantly improving the current stratification methods. So definitely a lot of work is going on, and AI methods will increasingly provide a powerful analytical framework for analyzing the molecular and clinical data. So just summarizing, it is definitely a heterogeneous disease. It is not a homogeneous disease. And broad outline, it is 4 major biological entities as of date. Subtyping currently uses more RNA-based sequencing, and it is still more in the research phase. We are still not adopting it in the daily clinics. I think so we should, and probably create our own data. The goal is to develop a simplified IHC panel. So that is a very, again, we have to simplify it to the various IHC markers so that we can very easily reproduce it in our labs. And definitely based on this, we definitely need a refined algorithmic approach for treating this difficult subset of our patients. So thank you very much, and over to the organizers. Thank you.
Thank you, Dr. Rajat, and making a clinical sense of all the lab work. And now I hand over the proceedings to Dr. Vaishali.
There are no questions in the chat box, but I have one or two, and I'm sure our other team members also must be having. So I have one question to Dr. Rajat. In Dr. Sunil's talk, he mentioned that in ER low on core needle biopsy, we should actually do a repeat IHC on the surgical specimen. Obviously, when it comes to triple negative or ER low, we usually treat with neoadjuvant systemic therapy. And then when we operate, if on the surgical specimen it comes out as a triple negative, so what will you use to guide future endocrine therapy for that? Will you consider endocrine therapy, I mean, against estrogen, or you will consider that as triple negative?
I would probably go in with a pre-surgical, or sorry, pre-chemotherapy specimen. I would put more weightage on that. If it is a ER low, if it is not
Okay.
ER negative, so any expression of ER should be given in endocrine therapy down the line.
Yeah. And the other question is to you as well as to Dr. Aparna. Can liquid biopsy be used as a kind of a surveillance for the relatives of BRCA mutation carriers as a means of surveillance? If they, anyone can take that.
Means of surveillance. So everybody asks as a means of surveillance. Means suppose we have a BRCA mutated patient, and we are screening the daughter of that BRCA mutated patient by doing a liquid.
Yeah, that is what is my question.
Surveillance means we will definitely do a germline analysis of the
She's
attendant.
asking ctDNA testing for
ctDNA, yeah, correct.
picking up those cancers before they present.
Yes.
So like the Eclipse trial that was done for colorectal cancers with like Garden Shield and that Galleri and all of these, what they're doing is that in high-risk candidates, they are using blood samples from where they're looking at methylation signatures to see if the cells are mutating or changing into being cancerous to pick it up for early detection. One is majority of the studies has not taken those individuals who are genetically predisposed. So Eclipse is one of the biggest trials that were done in colorectal cancers in particular. And they did not take Lynch syndrome patients, those who were genetically predisposed. So they took obese patients, diabetic patients, hypertension, CAD, but they did not take individuals who had a genetic predisposition. And what we also saw in not just, I can just think of that study right now because I was reading about it in the morning, that's why. But what we saw was that in that stage 0, stage 1, the pickup rates were very, very low as like 45, 50%. It's an NEGM paper. It was not the best pickup. So I don't think with respect to assays and platforms, using ctDNA as surveillance for a healthy asymptomatic individual who's genetically predisposed, I don't think we're there yet. There are some tests of using CTC and ctDNA, which some of our laboratories are doing. I think Datar got an FDA express breakthrough approval or something like that, and they are doing some great work over there. So maybe next year 27, 28, we'll be having far more robust data. But as of today, Monday morning, can I recommend it to our patients? I don't think we're there yet. Dr. Raja, do you agree, or do you want to add something to that?
Yeah, yes, I also feel that because we can just do a germline testing and find out if the patient is BRCA positive or
Yeah.
not. So that is done.
Yeah,
After
that
that, we
agree.
have to after that we have to rely currently on our clinical and radiological surveillance methods
Right.
that we can do. But doing a CTDN analysis, I agree with Dr. Aparna, we are not refined as yet in doing that.
Right. Yeah, thank you. I got my answer. Dr. Goel, Dr. Rajiv, Dr. Prekshi, Dr. Safalta, any more questions?
No, only I would say that the talks were really good and informative. Though for surgeons, it becomes a little too much to digest in one session, but definitely great talks.
So, one last question to Dr. Aparna. If financials are taken apart from, say, CGP testing, do you think it will be a norm to do CGP for all breast cancer patients at diagnosis?
I think we'll eventually get there with breast. Yeah, we'll eventually get there. I think we are seeing the power of molecular profiling. If not for immediate clinical action, but at least, people make fun of me when I say this, but it's the tumor talking to you. So if you upfront know what the tumor is planning on doing or planning on reacting, it will help you tweak it a little bit here and there. But we'll get there. I'm quite confident. I am seeing a slight change in practice, especially now affording patients where upfront metastatic, advanced metastatic disease, breast cancers, triple negative, hormone positive, HER2 positive, people are now starting to do CGP, maybe not for therapy, but at least to understand what are they up against, to maybe be a little bit more precise. Like the case I showed of Dr. Nitesh's, like, who would have thought an ALK fusion, right? So it was just because the patient was like, I don't want more chemo. I remember I was in Fortis those days, and it was like, I don't want more chemo. So it was a Hail Mary pass, and we just picked that up. And so random, something you see, 0.06% of your breast cancer patients. So slow and steady, we will start seeing that change in breast cancers for sure.
Dr. Aparna, just one question. My basic concern is like the heterogeneity which is there in a cancer upfront in terms of so many subclones with different mutations.
Right.
So how the tumor is going to evolve in response to therapy, which clones have the potential to survive or become dominant? Is it possible to predict from a day one analysis in terms of CGP?
So yes, there is, it's just because if I started presenting everything, I'd be speaking forever. But there is this really nice animation that I show of this picture of a hormone positive breast cancer at diagnosis, where they've done CGP, and at baseline, you are picking up, ESR1 mutations, you're picking up PIK3CAs, mix. These are all, and the MAP kinase pathway, these are all prognostic markers. So it does tweak your treatment. And somewhere that ESR1 is going to become your dominant clone eventually as a resistance mechanism to your endocrine therapy. You could have an NF1, which is another resistance mechanism. Sometimes it's acquired, sometimes it's there at baseline. So we do tend to see these resistance mechanisms eventually take over and go from being subclonal to, becoming the dominant clones. And that's where I think with combating, and what you made was an excellent point of heterogeneity. I think any cancer now we talk about, we're learning that it is heterogeneous. And in an ideal world where cost is not an issue, doing tissue and liquid actually helps combat this. So liquid is also not perfect. You are going to end up missing, there is a possibility that liquid can end up missing out on some key mutations. And that is why tissue also gets done. So I think we're slowly heading towards that, and absolutely bang on. Heterogeneity is a huge problem with our triple negatives, and especially with your HER2s and different sites, and you can see the expression change. Even in, when you do an IHC from that one, from that one block, and different corners, they are picking up different mutations. So you are seeing that heterogeneity, the subclonality. So to combat it, I do feel eventually CGP testing will be beneficial. In fact, now with liquid biopsies, you can actually use methylation signatures to pick up and say, is it hormone positive or is it HER2 positive? Sometimes you can't do a rebiopsy. So if it's a hormone positive patient, skeletal metastasis, very difficult going in and doing a rebiopsy, but you want to know if it's still ERPR positive, HER2 negative, or is it HER2 2 plus, 1 plus? You want some estimate, right? It does define treatment. So now with liquid biopsies, again, it's not robust, it's not 100%, but when I'm stuck in a situation like that, we are able to pick up even, that ERPR status, HER2 status, or it'll tell you it's 50-50. There is some clonality involved. So it is becoming a little bit more complex, but I think we're starting to also get a lot more information because we're starting to understand that information too.
And
Absolutely.
one more
Yeah.
question, like say in the clinical course of a cancer during treatment, let us say that the clones which develop or become significant, are they usually present at the time of first clinical diagnosis, or is it possible that there are new clones which are developing later during the course of treatment?
So we do tend to see that new clones do develop along, the patient's treatment journey. So there are studies that do show, I think the mirror study was one of the first ones where we did see a discordance between the primary site and the metastatic site. So forget liquid biopsy. Let's just talk tissue for 2 seconds. Even there, we saw that somewhere along the way, the tumor, had acquired new clones, new mutations, which was subclonal at that point, which eventually maybe the next thing could become the new dominant. So this is forever changing. It's rapidly evolving. It's definitely not static, the genomic landscape of our cancers. So any patient that's undergoing treatment, targeted therapies, hormonal therapy, there is always some change that is happening with your patients. So that's why every time there's progression in an ideal world, they say, oh, we should see what the biology is. And you do tend to see changes, but it's astronomically expensive to ask somebody to do that. But yeah, but studies and trials have proven that, yes, we do tend to see that a lot of clones get acquired along the way.
Thank you.
So if there are no more questions, then I will play my role of, saying word of thanks to. So I'll begin with the attendees. Without you, we would not have been, carrying on with these webinars. So for last 2-3 years, we have concluded 3 successful webinars, and now the new series. Today's was the 6th one, and very well attended. 100 odd people in the audience. So thank you so much for giving us inspiration to carry on. Then my distinguished faculty members, you have been wonderful. I personally got so much of knowledge today, and I'm sure with molecular biology taking over the routine clinical and general histopathological characters, probably we will get new answers to those questions which we have been grouping for so far, especially in management of triple negative and HER2 positive breast cancers. So thank you so very much, all the faculty members, Dr. Rajat, Dr. Aparna, Dr. Sunil, and Dr. Jyoti. You have been really wonderful. Thank you so much for taking out such a precious time from your busy schedule. And I'm sure, I hope you will be joining us in our future webinars as well. I thank Dr. D.G. Vijay sir for allowing us to join hands with ABSI for carrying out these webinars on this new series. So thank you once again. I thank Mighty Duo people for this technically flawless execution of these webinars, and the communication with the faculty members as well as with the attendees. So thank you all. And I thank all my team members, my seniors, my other colleagues who have been helping us, conceptualize and execute these webinars. So we will be coming back with our 7th webinar in the series of this master course in breast cancer very soon. So Once again, I would like to thank you all and have a